Good evening, everybody. I welcome you all for this very interesting smart class webinar on PCNL. So it's a very dear topic to all the urologists because you see it, you read it, you listen to it, you see it so any number of times. Still, you feel like watching this program again and again because PCNL is ever a fresh topic for us. And because this another unique thing about this smart class is this is the last smart class of this year. So our ISU chairman, madam, will be joining in a few minutes. So we have Dr. Sunirmal Choudhury, who is the convener for this webinar. We chose him because he has got a lot of interest in urolithiasis and has done great work, published good work, and he has something goes. I was just reading about his work, Calcutta position for supine PCNL. So we're going to hear a lot about this technique, and he has chosen a very excellent faculty who is going to deliberate on different aspects of PCNL. That's how we have coined this name of this webinar as All You Need to Know. So it's my pleasant duty to introduce the convener for this webinar today. Dr. Sunirmal Choudhury is the professor and head of the Department of Medical College, Government Medical College, Kolkata. We all know he's the honorary secretary of the East Zone, and he was earlier the honorary secretary for the Bengal Urology Society, and he was also the organizing secretary for the Eurolithocon, which was a very successful conference. And he's got many credits, awards to his credit. He's got the Duscan Gold Medal for the best international publication from the North Zone. He's got USI Olympus Traveling Fellowship, Siliguri Traveling Fellowship, and he has got the prize for the supine bullseye puncture in Calcutta position, which he thought it's going to be a game changer in supine PCNL. So now it's my pleasant duty to hand over the session to Dr. Sunirmal. Before we start the session, we have Honorary Secretary of USI, Dr. Uttam sir, with us. So he's so busy. We all know that our ECCON National Conference is approaching. He has so many things to do, but very thankful to you, sir, for joining this webinar. And I request you to give your opening remarks for this webinar before we start.
Thank you, Dr. Surya, for your opening remarks. And I can see all the faces. I think I am amongst my own home only. I'm sitting here, so all people very close to me. And so good evening, everybody. And as I understand, as has been told by Dr. Surya, who is going to take over as chairman of the ISU after 1st of February, he told most people this is the curtain. They are going to close the curtain for this year. So, but behind the curtain, so many things had happened. They were also actually busy throughout the whole year. And but rather than telling about the PCNL, everybody knows. So we have something to discuss about the technique and technology, isn't it? I still remember my earlier days when my few of my abstracts were accepted in AUA. That was on Staghorn stone. Now I don't think, because that time they never used to see Staghorn stone because all used to be in these countries only. So it was accepted most probably. But nowadays the things have changed in India also. Now the incidence of Staghorn stones, I don't know whether other people will agree or not. We are doing less and less number of Staghorn stones at least. We are getting more and more number of smaller stones where RIRS is going to be the competitor rather than the PCNL. So I'm not going to open the debate, but definitely the stalwarts are there to speak about PNL, different techniques and technologies about prone, supine, and all those miniaturization. And definitely it is going to help us a lot. Before I say goodbye, I think I would like to say that this time I am always a fan of live surgery because you can learn a lot and you can communicate, say whatever you can say. So this time we have been able to manage this live surgery as of now, and it is going to be passed in the council. And so the live surgery will be on day one and day two. Day one hardly in the morning, and day two will be in the evening, and that will be usually from overseas surgeons, by the overseas surgeons, operated by the overseas surgeon. And this time, most of the abstracts will be finished by day 1, 2, and 3. And day 4 will be mainly video abstracts. Because I have seen in the last day, everybody, tries to run away. and it's very difficult. Even if I have kept four chairpersons, nobody is there in 1 or 2 sessions. So please encourage all your residents. By this time, I have already published the abstract schedule, not only the accepted or not, the schedule, and which day, which hall, it has already been published. I have posted in the WhatsApp group, and the whole program is going to be published in a few days' time after it is being approved by the council. The council meeting is going to be held in the weekend. So with these few words, and I hope to see you all there in Indore. Come, everybody should come, and it should be a very successful UCCon. With this, I say good luck to this webinar, and thank you very much.
Thank you.
Thank you, sir. Thank you. Madam has joined, Sujata ma'am.
Yeah. Thank you, Uttamete sir, and thanks for all your support. This is the last webinar for this year, and you have always come for all the webinars and been throughout it. So thanks a lot. I request Surya to please conduct it, and I'll be there in the end to thank everyone.
I just want to have one query. Do you have PCNL also in your cadaver program?
No, sir.
No. So why don't you start that?
Sir, how to put stones inside? The kidneys are usually in ATN, so kidney quality is very rarely good in a cadaver because they are in ATN, so slightly flabby kidneys. So I don't think we can take punctures and all.
Correct.
Because people from Sri Lanka, they are praising you like anything for your cadaver program.
Yes.
Surya was there.
Yeah, they had come for the cadaver program. 2 students from Sri Lanka.
Okay.
They enjoyed it.
Okay, without wasting the time, I think we should go ahead.
I think that Rajiv sir is not there. I reminded him, maybe he's very busy. Ma'am, can we start, ma'am?
Hello.
Good evening, sir.
Yeah. Sunirmal,
So
we can introduce the faculty.
Yeah, please start.
Yes. So without wasting time, I am going to start this program. Our first presenter, Dr. Malay from Bera. Dr. Bera is a very senior neurosurgeon in West Bengal. He's previous HOD of IPDMR and Medical College Calcutta. He's a really renowned urologist. So I call upon him to present safe supracostal approach for PCNL. Dr. Bera, please.
Full. Good evening. Can you hear me?
Yes.
Good evening. I'm grateful to the stalwarts of the Indian School of Urology and Dr. Sunirmal Choudhury for giving me opportunity to share my knowledge of this safe supracostal approach for PCNL. On introduction, the PCNL remains the most effective procedure for large volume stones or complex renal calculi, and success relies critically on the optimal percutaneous access. Though these are mostly intracostal, supracostal approaches are avoided for fear of the complication, but in many centers, they follow the supracostal approach because of some advantages. We know that ideal puncture is straight, least parenchymal depth, and accessing the maximum stone burden without much torque and through the fornix. And from the upper pole calyx, it is versatile to enter almost all calyces, other than this posterior mid calyces. Otherwise, almost all calyces we can enter from the superior calyx. So what is the definition of the supracostal? This is just all the punctures above the lower edge of the 12th rib is supracostal access, and it should be done in the full expiration. And in full expiration, almost 80% of the upper calyx is located above the 12th rib. The entry above the 12th rib is chosen if indicated. Entry above 11th rib is rarely done, but entry above 10th rib is only done by the very experienced urologist, and it is also very rarely done. My objective of this presentation is to know the anatomy, indications, and contraindications, and detailed tips and tricks for safe puncture and take-home message. I cannot see here. Now, if we come to renovascular anatomy, now we can see the posteriorly, the large vessels are present at the infundibulum of the superior calyx, but anteriorly, those are uniform, almost uniformly distributed. I can see it. Now we can see in this picture that if we puncture from the superior part, there is chance of the injury to the upper vessels if we puncture at the infundibular part. So the puncture should be through the fornices if we approach from the supracostal side. And also in the intercostal spaces, the vessels run just under the ribs. So we have to puncture from the upper margin of the ribs. Now there are various types of the calyces which have been published by Sumpia et al. That now this is a type of the calyx where you can see this is a narrow and long infundibulum. If stone is present in the upper calyx, then we are bound to approach it supracostally and maybe above the 11th rib. Also, there are multiple stones in the upper calyx, which is high up, and probably you have to choose the above 12th rib. Now, if we consider the pleural reflection and ribs, the lower limit of the pleural reflection crosses medially the 12th rib and extend down into the costo-diaphragmatic recesses. The 12th rib, in 12th rib axis, the puncture of the 12th rib carries a moderate risk, 5 to 10%. And 11th rib axis, the puncture of 11th rib, almost 50% of the cases, there is chance of the injury to the pleura. The diaphragm's role is also there. In case of the inspiration, diaphragm contracts, moving the pleural recess caudally, reducing the safe zone. In expiration, it gives much safe zone, maximizing the safe zone, and it pushes cranially. So where is the safe zone? You can see in picture, in expiration, you can see the pleura goes up, giving a very much safe space above the 12th rib. In inspiration, it comes down. Almost there is no safe space. And in expiration also, in medial to the mid-scapular line, there is also a small window of safe place above the 11th rib. So what are the potential complications? The complications are injury to the pleura, injury to the lung, leading to pneumothorax, leading to hydrothorax, hemothorax. And if there is delayed diagnosis, there may be much complications. So we have to be very much vigilant about that. Improving the imaging, either CT, fluoroscopy of Shyam, real-time ultrasound, we can know very well the relation of the calyces with the ribs as well as the surrounding viscera. Here you can see easily the position of the calyces. Here is the upper calyceal diverticular stone, you can see easily. So we can plan our puncture and direction of the puncture. Now, what are the indications? Upper pole calculi, the primary indications are the solitary or dominant stones located internally in the upper pole. An infracostal approach may be done, but in that case, there may be much torque and obliquity. Staghorn calculi, the upper component of the Staghorn calculi is easily managed by the supracostal approach. In lower part, there may be requirement of the infracostal tract, or we can use the flexible scopes through the upper puncture, upper tract, and manage them. What are the anatomical variants? Anatomical variants are renal malformation high up kidney, and where the kidney sits above, it is unusually high. Then we have to puncture above the 12th or 11th rib, sometimes above the 10th rib. Calyceal diverticula, I have already told, in upper pole there may be calyceal diverticula which requires supracostal puncture. Failed socket lithotripsy. There may be small stones in the upper calyx and there may be narrow infundibulum where you have to approach through the supracostal route. In case of the prone position, the supracostal approach is much done. But in case of the supine PCNL, also we may need supracostal puncture, and in very experienced person they use supracostal. But in general, there is more chance of the pulmonary and visceral injury. But according to many authors, this is not true. But if we go through this paper of Professor Bhaskar Somani, their conclusion is that these procedures must be done in experienced endocrinology units. What are the contraindications? We know the absolute contraindications, those will be discussed later on also. The specific contraindications are severe pulmonary compromise in case of the COPD, active pneumonia, or pulmonary reserve where there is less pulmonary reserve, or there is some thoracic surgery or pleural diseases, where there is uncertain anatomy, where we cannot depict the marking of the pleural boundary, then we better to avoid the supracostal puncture. The diaphragmatic position is also important. In preoperative planning, if you see the diaphragm is very high, particularly in case of this diaphragmatic hernia, they are better to avoid those because it may cause injury to the viscera also. Now, what are the tips and tricks for safety puncture? We have to preoperative planning with the CT scan and other imagings. We have to map out the puncture tract, and we have to mark over the patient before puncturing. Respiratory maneuver. This requires very much good coordination between anesthesiologist and surgeon. Anesthesiologist should momentarily stop ventilation when the surgeon is puncturing, and it should be in full expiration in end-tidal breathing. Puncture trajectory. The aim of our target through the calyxial fornix through the superior border of the rib. The safest option is other than the 12th rib. If it is above the 11th rib, it should be just above the margin of the 11th rib in full respiratory control. Avoid traversing the mid or upper part of the intercostal space. It can risk the intercostal neurovascular bundle. Now, what are the additional maneuvers we can use? We can displace the kidney, but another tract. We can use the puncture needle by puncturing the lower or mid calyx and drawing the kidney downwards, and also angulated oblique tract in triangulation as shown in the picture. For
I think
guidance, fluoro versus ultrasound. The real-time ultrasound guidance is excellent. Yes, I'm just giving you the post-operative management is the chest X-ray is mandatory within 2 to 4 hours, or the patient complains of the chest pain, and this treatment is small. If it is small, we have to conservative management. If it is large, we have to use the chest tube and water seal drainage. And in conclusion, supracostal approach is a critical skill for the treatment of the complex upper pole renal calculi, offering superior stone clearance compared with oblique unstable torque-related lower punctures. For safe puncture, measure twice, think twice, puncture once. Meticulous preoperative imaging, full respiratory control during access, and mandatory postoperative chest imaging are non-negotiable standard of care. Master these techniques and maximize your success. Thank you.
Thank you, Dr. Bera. Hello. Am I audible?
Yes,
yes, you're audible. You're audible.
So, I want to ask one question. So you told that the puncture should be done in inspiration. So does it really matter? Because whenever we are doing PCNL-GA, we have to ask the anesthetist to pump the bag so the kidney comes down. So then it is in full expiration.
In some cases, some of the centers, the urologist may try to bring down the kidney with the full inspiration, but definitely along with that, pleura and lung will come down, and you have to judge that whether you are going to injure. In experienced urologists, they can do in inspiration, but the safe zone will increase if the puncture is done in expiration.
So, do you recommend that this prone PCNL will be done in supine in a spinal anesthesia in case of upper clinicial puncture? Does it help? No. In prone PCNL, does spinal anesthesia help?
In many of the centers, they do spinal anesthesia. In spinal anesthesia, if the time remains limited to 1.5 hours. In supine patient, I ask the patient to, and if this complete little bit control their breath, and if it requires much time.
I think there's some disturbance in the internet.
And better to do under general anesthesia.
Yeah, we'll move on, Dr. Sunirmal. We can take the question.
Thank you, sir. So, we'll
Thank
go
you.
to the second presenter, Dr. Soumya Mandal. Dr. Soumya Mandal is Associate Professor of Urology. Hello.
Soumya.
Hello.
Yeah. Hello, am I audible?
Yes. Dr. Soumya Mandal, Associate Professor of Urology at IPGM here, and he's doing urology practice for quite a long last 10 years. So, without wasting time, I'm inviting Soumya Mandal to present his topic: Staghorn, Calculus, and PCNL.
Thank you, Sunirmal. Thank you, Sunirmal sir. Thank you, ISU, for giving me this platform to present myself. I'm really thankful to all. Well, my topic for today is Staghorn Calculus and PCNL. So, in this today's class, I'll primarily focus on management of Staghorn calculus, which are mostly complex and associated with infection. I will discuss standard versus mini PCNL. I will discuss single versus multiple track PCNL along with hybrid approaches like ECIRS. The object, so which I would like to put forward, I would like to review the current literature. I will try to analyze the technical notions. I'll try to discuss the predictors and the management needed for complete stone-free rate. A little words about Staghorn Calculi. You know all these are complete or partial, and they are typically struvite stones. For stones, the primary modality of investigation is non-contrast CT scan. It is a gold standard because 3D reconstruction can be done, and it also facilitates pre-op planning. We can assess spatial distribution of the tract. The limitations are radiation exposure, and no functional information is available in the non-contrast CT. Functional imaging is also important in some cases. Here you can do a DTP or a MAC3 nanogram. Yeah. Mostly the common type of stones are the magnesium ammonium phosphate stones, and the type of mixed stones are associated with calcium phosphate. Knowing the type of stone is important because of determining the energy motility during operation or surgery. And struvite stones are mostly important for knowing the organism involved, Proteus and Klebsiella, and their recurrence. Now, before managing a stone, this classification system is in vogue, which is really helpful. We should the most important and the most commonly used is the Guy's stone code. It assesses the stone complexity. They can be graded into 1 to 4 based on the number, location, and stones. Higher the grade, the less is the stone-free rate. In the stone score, it's also the same, while the Pro score is also the same, but these are less frequently used. So, in management of Staghorn calculi, our goals should be complete clearance. Our goals should be to preserve renal function. Our goals to prevent recurrence and minimize complications. So, this is a treatment algorithm. First, we should classify the stone, whether it's a partial or Staghorn, and according to the management. Next, we should assess the kidney function. If it is less than 10% function, PCNL is normally of no use. Third step, we should control infection. As we know, mostly these are infected. It can be done in the form of antibiotics or in the form of some sort of drainage, either in the form of PCN or a degenerating. Then the most important step is before taking out the stone, we should evaluate the renal anatomy. If it is a favorable anatomy, standard PCNL is not. If it is a complex anatomy, it may need multiple tracks, it may need ECIRS, it may need supine PCNL. Our main target should be ensure complete stone recurrence. And second loop PCNL or URS is required in the second time. So normally the standard PCNLs can be divided, which are routinely used are the standard PCNL, the mini PCNL, the auxiliary PCNL, that is the PCNL with RIRS. In the PCNL part, we can use a single puncture, we can have a multiple track PCNL. Open surgery is very rarely used now, and nephrectomy is reserved for non-functioning kidneys. So in mini PCNL, we have lower grading. I'll come to this later on. So why is PCNL the mainstay of Staghorn Calculi? According to the UA guideline, these are the first line of treatment. And according to them, the PCNL achieves more than 70 to 90% stone-free rate in complete Staghorn. And in mini PCNL or ECRS may be necessary in stress sensors or in complicated stones. Why shorter dysautoropsy, RIRS or LAP was not routinely recommended in Staghorn Calculi? Because of their ineffective clearance rate and longer operative time and high morbidity. So according to EAU, PCNL remains the gold standard for Staghorn Calculi because of its safety, efficacy, and adaptability. So in summary, shockwave decompensation is not normally recommended. RIRS can be used as an adjunct procedure, and ECIRS can be used in complex cases, but that in PCNL in supine cases normally. Normally, RIRS is not ECIRS is recent phenomenon where it can be helped in limited extensive Staghorn requiring multiple procedures. Now, how to do a PCNL? How to do a planning? Normally, the first puncture is normally by the fluoroscopy or ultrasound. In supine position, the posterior lower pole calyx is the optimally chosen one because they have the minimum skin to stem distance, and we should choose a access which is directly to the renal pelvis or the stone wall. But this may face problems if the patient is obese or there is spinal deformity. Retrograde colon, although rare, may be present. The puncture techniques were normally used are for the fluoroscopy techniques, ultrasound guide techniques, and we can use combined fluoroscopy and ultrasound. And the recent phenomenon is endoscopic assisted, where the uteroscope is present inside the collecting system, and under direct visual puncture, puncture is done. Normally, it has the highest accuracy for difficult calyxes. In fluoroscopy guidance, these are the three puncture techniques used. We have the gradual descent, where the intended calyx is present in the center. We gradually descend the needle. We check it in angled shear. We then check it in 0° shear. We then further descend the calyx, and so on. Pulsar is the most easiest to learn, where the tip of the needle just is placed on the calyx and looks like a bullseye. Triangulation technique, although definitely is very satisfying, but it's difficult to learn. It uses the technique of mathematics and trigonometry. And the most commonly used is gradual descent. How the tract is dilated. Normally in standard PCNL, we dilate with the help of ampulas, alkanes, or Delu up to 24 to 30 French. Whereas in mini PCNL, we dilate normally up to 12 to 22 French. We must remember the smaller the tract size, the lesser is the chances of bleeding. But simultaneously, smaller the tract size, the irrigation fluid also becomes lesser. So there is vision. Larger the tract size, according to the available instruments, the instruments are easily workable. So in mini PCNL, we have both the the problem of lesser vision as well as limited resources. What are the energy sources used in our lithotripsy? We have the ultrasonic lithotripsy, which helps both in fragmentation and suction. They are normally preferred for soft stones. The most commonly used is the pneumatic. It is fast. It can break dense hard stones also. In mini PCNL, where we are my mini or micro mini, laser, holmium laser may be helpful. But in all cases of PCNL, one thing to remember, we should avoid over dilating, especially in upper pool cases, where Professor Bera has been teaching. Here we have risk of pleural breach, we have risk of injuring larger vessels, which are commonly over there. And we should limit operative time to less than 70 minutes to reduce sepsis. So, what does the guidelines say? What does the evidence say? In stone-free rate, we can achieve more than 95% in PCNL, especially when it combined with staged or adjunctive procedures. The success factors depends on the energy modality use and the planning. So mini PCNL is always safe, and our first target should be mini PCNL. Here, the access is similar to standard PCNL, but the track size is much smaller. Normally, in very small micro mini or mini cases, laser can be used, and problem is with vision and the number of instruments used. Here you can see the operating time is also slightly longer in the mini PCNL, and the bleeding risk is lesser in the mini PCNL. A stone-free rate is almost similar. So the ideal conditions for mini PCNL is partial Staghorn, but the surgeon should be highly experienced, and patients with bleeding risk and pediatric cases, this should be the ideal technique. But there is a working place concept. So mini PCNL should be chosen in cases we are pediatric, we have high bleeding risk, and the stone burden is low. And standard PCNL is normally chosen where we need a wider access, we have a need for multiple punctures, we need for single session clearance, and we have a high volume Staghorn. So this is a compilation where limitations of mini PCNL are the reduced irrigation, a limited compatibility with instruments, and another thing is that mini nephroscopes are often prone to flexion injury. We can lose our nephroscope also. So experienced surgery is very much necessary. The next thing is multi-track PCNL in case of single track, where a multiple track is needed, where a complete Staghorn calculus with calyxes, which is inaccessible from a single track. We may have a parallel calyx. We may have a track where this calyx puncture is not negotiating. Our goal is always to have a high stone-free rate. So the stone-free rate in cases of multi-track PCNL, what the literature shows, this shows that the stone-free rate up to 95% in some cases. And why do you need a multiple puncture? This will need a reduced need for secondary procedures. But what are the risks involved? In multiple cases, there are higher chances of bleeding, higher chance of parenchymal injury. Staggered tracks is one of the cases, the complications of a multi-track, where inter-track parenchymal damage is done. There the chances of infection is also more. So in some cases, we don't go for multi-track, we go for stage PCNL, or the PCNL in the second time through the same route. Here, where we compare, these results are almost comparable.
I think you have to wrap it quickly now.
So bleeding risk is lesser, sepsis rate is higher in multi-track PCNL. So this is a.
You can skip few slides. You can skip few slides and come to conclusion.
So when you are comparing with ECRS or multi-track PCNL, the thing is that ECRS and multi-track PCNL are done in cases of special cases where multiple traditional puncture, multiple complex stones. Now, Coming to the complications, the most common complications are hemorrhage, visceral injury, and collective duct injury. The complications can be divided into early and late. This is after within first 22 hours, hematuria, fevers, UTI, sepsis. These are the most common. Late common causes are residual fragments, recurrent UTI, left fistula. This fistula may need closure or intervention. These PCNL complications can be classified according to Kelvin Dito also, where grade 5 is death is very rare. Grade 4 is sepsis with ICU stay. This is also rare. Most common or is grade 1 with the mild fever or transient infection. So how do you prevent? So to prevent, we need to have a sterile urine. We need to have an optimized coagulation profile. USI cardiac puncture may also be done to limit operative time less than 90 minutes and control interpelvic pressure. So the last part of PCNL in solitary kidney, special resort pediatrics are high risk cases. So first we have to manage, we have to plan, the idea is to preserve the renal function and the maximum stone clearance. So mini PCNL goes with that. So in case of solitary kidney, even minor bleeding can cause significant renal compromise in pediatric patients also. So we have in mini PCNL series solves both the need. Then the recurrent Staghorn calculi normally results from residual fragments or inadequate metabolic workup. Non-compliance with treatment also is one of the proven reasons. So coming to the end, what are the algorithmic surgical radiation? Coming to the basics, the seed is the same. First, we should evaluate the renal function. We should assess the renal stone burden anatomy. The stone operation should be patient specific. Not all patients need the same treatment, and post-op planning is also important for residual fragments. So in short, complex Staghorn needs standard or multi-track PCNL, where there's complex pathway, ECIRS might help. In pediatric and infected stone, in pediatric patients, mini PCNL, in infected stone, stage PCNL, and in non-vascular unit. Now, my last slide. Is complex stone free status always necessary? This is the latest journal I could achieve. And they say residuals less than 1 centimeter are often stable. The renal function is almost preserved, and culture positivity does not mean the patient is going to have a poor prognosis. So the clinical takeaway message is for me is that aim for maximum clearance, but avoid aggressive surgery. If the patient is a high risk, residuals which are clinically insignificant can be followed up. No further surgery is needed, and renal function should be preserved at all costs if possible. Thank you.
Thank you so much. I request all the presenters to stick to the time because it is every presenter should talk only for 20 minutes, and then we have, if you talk for 12-15 minutes, then there will be no time for question and answer. So without wasting time, I am going to the next presenter, Dr. Puskar Shyam Choudhury. He is the Professor Head of Department of Urology, KPC Medical College, and Director of Urology, Fortis Hospital and Kidney Institute. He has a keen interest on RS and pediatric PCNL. So, Puskar, are you there? Puskar Shyam Choudhury?
Yeah, Sunirmal, thank you. And am I audible?
Yeah.
Okay. So let me share the screen.
You have not shared the screen. No, it's okay.
Yeah, now it's okay.
So already Dr. Soumya Mandal has highlighted about the need of mini PCNL and our gradual movements toward miniaturization of percutaneous nephrolithotomy. So we would all like to achieve a small scar like this. This was in a 5-year-old child with a small mark. You can see compared to the banded mark for a large Staghorn calculus like this. So a smaller tracts leads to lesser morbidity, lesser hospital stay, and lesser bleeding. The gold standard is standard PCNL, which uses a large access sheath of 24 to 30 French and is the primary treatment for complex kidney stones exceeding more than 2 centimeter, as recommended by most of the associations. Despite the high efficacy of standard PCNL, it carries significant morbidity like excess hemorrhage and transfusion rate of as high as 3 to 6% of cases, and there might be adjacent organ injuries, systemic infection complications, including postoperative fever. So the standard PCNL uses earlier we used to have a 27 French nephroscope. Then we had an integrated 24 French nephroscope, and most of us now use a smaller nephroscopes of 21 French, which allows instruments of the size of 3.5 millimeter diameter. Mini PCNL involves using smaller scopes and smaller sheaths. So we have accessory instruments with the scopes. The scopes are as small as 12 French with a 12-degree vision and angle vision, and they have individualized sheaths which helps in the irrigation. We use specialized dilators mostly in the mini PCNL, which are metal dilators, and we have miniaturized instruments of 2 millimeter which can be used to extract fragments in case we are doing a mechanical lithotripsy. Ultra mini PCNL use further smaller scope of size almost 3 French, and this generally uses water jets to clear the stone fragments and mostly uses lasers. Now the access morbidity paradox. So with miniaturization, we can reduce the morbidity, but at the same time, we increase the operative time, the intra-pelvic pressure, which might lead to complications. The clinical advantages are reduced mechanical trauma, lower blood loss and transfusion rates, shorter hospital stays, and the technical limitations are the restricted irrigation flow, longer operative times, elevated intrarenal pressure. So a successful mini PCNL requires advanced fluid control systems to manage the elevated infection risk from poor outflow and high intra-pelvic pressure. So there are discrepancies in nomenclature. The generally accepted one is the ceiling classification, which shows M size, which is 15 to anything which uses a sheath of less than 22 French can be considered as a mini PCNL. And the ceiling classification shows that the 15 to 19 French is M, the small size is 10 to 4, the XS is 5 to 9 French, and the XSS or micro PCNL is a nephroscope size of less than 5 French. There are other classifications as well, like Tipler system. So in establishing a consensus on nomenclature is essential, because then we can compare head to head with the different complications, and it helps us in comparing the literature. The spectrum of miniaturization, the standard PCNL, the sheath size is above 24 French, so 24 to 30 French. Primary indications are large, complex stone Staghorn calculuses. Stone-free rates are high, almost 95%, and transfusion rate maybe 3 to 6%. Mini PCNL, 14 French to 22 French size sheaths are used. Medium to large stones, 10 to 30 millimeter stones can be managed with mini PCNL, and comparable, the stone clearance rate is comparable to standard PCNL, and transfusion rate is much lower. Ultra mini PCNL, these are 11 to 15, 13 French sheath size. Small to medium size stone, less than 2 centimeter stone should be used. And these have lower stone free rates of 85 to 92% and may need ancillary procedures, and blood transfusion is not reported. And in micro PCNL, again, the stone free rate is slightly lower, and blood transfusion rates are not reported. The all-seeing needle is the extreme miniaturization of PCNL. So it uses a 4.85 French all-seeing needle incorporating a 10,000 megapixel pixel camera and a 120-degree field view. It has an integrated sheath and irrigation system. The historical evidence shows that most post-renal biopsy bleeding becomes negligible when the needle tract is less than 16 gauge. So with this use of this scope, the chances of bleeding is almost nil, and this can be used in patients who are on active anticoagulants. The stone-free rates across the tract size. So as I mentioned that for standard PCNL and mini PCNL, the stone-free rates are almost the same. However, for ultra mini or the micro PCNL, the stone-free rates are slightly lower, 85 to 92%. And randomized control trials demonstrate that mini PCNL has higher stone-free rates than flexible ureteroscopy when treating 10 mm to 20 mm renal stones. So RIRS can be limited to stones less than 10 mm up to 10 mm, and between 20 to 30 we should prefer mini PCNLs, validating the strategy of preserving renal tissue without sacrificing treatment efficacy. Morbidity reduction, the primary advantage, it reduces the blood loss, minimal transfusions are required, rapid recovery. Total tubeless mini PCNL for 10 to 30 millimeter stones achieves a 95.5% stone free recurrence, and the hospital stay can be minimized to almost 1.5 days. Another advantage of using mini PCNL is it helps to negotiate in difficult tracks and smaller calyces, and reduces the torque exerted on the calyces while manipulation. The operating time trade-off. So standard PCNL, we can do it faster, demonstrate significantly shorter operating time compared to mini PCNL, with mini PCNL requiring slightly higher time, almost 10 minutes more if we use mini PCNLs. So the restricted challenges are it reduces the irrigation flow, impairs the visibility, and slows the passive fragment evacuation, demanding more time for meticulous fragmentation and retrieval. The solution is using some advanced technologies like suction-assisted mini PCNL with mechanical retrotripters, which achieves almost comparable evacuation time and operative time. However, laser devices have slightly higher operative time. Active fluid and fragment management systems combined with high power lithotripsy successfully can balance the time efficiency against low morbidity benefits. So the treatment algorithm, when to choose the mini PCNL, literature shows that a meta-analysis published in the Journal of Endourology has shown that RIRS, the stone size, we should prefer to have less than 21 or 22 millimeter, and the stone volume less than 15 cc, minimal invasiveness. The advantage is the minimal invasiveness. Mini PCNL somewhere between 20 to 35 millimeter. The stone volume should be intermediate, and optimal efficacy and safety balance. And standard PCNL should be kept for larger stones of greater than 35 millimeter because it ensures maximum stone clearance. So mini PCNL occupies the essential bridging role, enabling safe treatment of burdens too large for RIRS, but carrying unnecessary risk if addressed by standard PCNL. The intrarenal pelvic pressure, rise in intrarenal pelvic pressure is a critical safety challenge in cases of mini PCNL. The restricted outflow in small tracts inherently leads to the pressure elevation during irrigation and stone fragmentation. And IPP of less than 20 centimeter of water is acceptable. However, in mini PCNL, it can go up to 30 to 40 millimeter of mercury. So meta-analysis shows that mini PCNL is associated with significantly higher IPP and compared to standard PCNL, with a mean difference of almost 8.31 millimeter of mercury. So we should have a device that can reduce the intrapelvic pressure. Excessive intrapelvic pressure drives pilovenous backflow, causing systemic absorption of irrigation fluid and fundamentally altering the clinical risk profile. So with an elevated IPP, there is a restricted outflow, increases the intrarenal pressure, the pilovenous backflow, which leads to bacterial translocations and postoperative fever. However, meta-analysis has shown that mini PCNL has comparatively postoperative fever rate compared to standard PCNL if suction devices are used. So to reduce this IPP, we should use the suction technology. There are specialized suction access sheaths actively aspirate the fluid and stone fragments from the collecting system. This maintains a low pressure. It enhances the visibility due to the high flow irrigation channels, which leads to an whirlpool effect, and speeds the fragment retrieval, leading to efficient evacuation and reducing the operative time. Normal saline must be used exclusively for irrigation, as it's isotonic and minimizes the risk of hemolysis or electrolyte imbalances. Now, these are the different mechanisms by which stone fragments are evacuated. So, in mini PCNL, we have mainly the inflow through the nephroscope and the outflow through the sheath. However, in the mini PCNL, it can be through the suction sheath and the irrigation outflow, or there might be inflow from the suction sheath and outflow from the nephroscope. However, in ultra mini PCNL, the inflow is always from the sheath and the outflow is from the nephroscope. So there are different effects by which these are done, the whirlpool effect, vacuum cleaner effect, suction sheath effect, etc. Now there are specialized applications where mini PCNL is needed, like the pediatric patients. Small PCS necessitates miniaturization to minimize torque and accessibility to the calyces. High-risk patients, like minimized bleeding risk, allows cautious performance in patients on anticoagulation. Tubeless procedures can be performed with the help of mini PCNL, and that can reduce the hospital stay. And for multiple punctures, we should prefer mini PCNL compared to standard PCNLs. The ability to perform complex stone procedures with minimal trauma enables ultra-short stay surgical models, profoundly improving the institutional efficiency and patient quality of recovery. Now, specialized instrumentation is required for mini PCNL. So we should have smaller scopes, 6 French scopes for ultra mini PCNL or 12 French scopes for mini PCNLs. And dedicated dilator sets should be kept. These are generally metallic dilators. Suction access sheaths should be used to reduce the operative time and the intrapelvic pressure. And laser lithotripsers are most commonly used in ultra mini PCNL and micro PCNLs. However, with mini PCNL, we can use mechanical devices as well. The lithotripsy technique combination, if we compare the mechanical with the laser lithotripsy, we see that the lithotripsy time is more with lasers. The total operative time is more with lasers. However, the transfusion rates are less with lasers, significantly less. So the mechanical devices provide superior efficiency, but with critical increases in the major complications, including transfusion rates and pelvic perforation. For the smallest tracks, tissue integrity prioritization often dictates laser lithotripsy over faster mechanical alternatives. The learning curve for a standard PCNL, we know that the initial experience, you recover 1 to 15 cases. For competence, almost for 45 to 60, and for mastery, more than 100 cases. However, being proficient in standard PCNL does not automatically confirm competence in mini PCNL, because here you have to learn to use smaller instruments, reduce the torque, and use miniature tracts, no ultrasound guided puncture. And so it requires a distinct skills acquired through dedicated training pathways such as master classes or simulation based models. Economic analysis, we got an US based analysis which shows that the initial investment for mini PCNL is significantly more compared to a standard PCNL. But if you keep on doing mini PCNL, reducing the hospital rate and complication rate if they are considered, so the break even is 5.51 patients. So more than 6 patients if they do in US, so they can, it becomes more cost effective to do mini PCNL. We don't have such study in India. Future directions, technology integrations, miniaturization is being done in everything, like chips and all. The next era of super minimally invasive PCNL, which will reduce the tract size and reduce the complication in the hospital stay, maybe it will become a daycare surgery. So we should, the future is robotic platforms like automated targeting systems, refine the renal access accuracy, standardize puncture trajectory, and reduce radiation exposure. 3D navigation systems which enhance anatomical visualization facilities, precise targeting, and minimizes complications through renal real-time guidance. And artificial intelligence can predict from the images the ideal puncture or the ideal method of surgery, whether it's an RIRS PCNL or a mini PCNL. So to summarize, mini PCNL's foundation lies on smaller tracks between 14 to 22 French sheets. Individualized decision making for, we should choose mini PCNLs as per the requirement, like for pediatric patients for multiple tracks, stone sizes between 20 to 30 millimeters. We should have devices for active fluid management to reduce the intrapelvic pressure and reduce complications of sepsis. Specialized training is required for mini PCNL. We should practice, we should be convenient with standard PCNL and then migrate to mini PCNL under supervision. And technology integration is the future to reducing the size of the tracks and reducing complications.
Okay, thank you, Puskar.
So I conclude with one of my bosses, him from Rahim, who said that jahan lage sui, wahan kya kare talwari. So when you require miniaturized, you should know how to do mini PCNL, and probably the future of mini PCNL is these nano robots to break stones in situ. Thank you.
Thank you, Puskar. Very nice presentation. I want to ask one question. How to measure internal pelvic pressure?
The intrapelvic pressure you can measure with the side, these suction tubes when you use, because they are a sealed compartment. You can use it with a manometer, which can measure the this intrapelvic pressure.
Any company device is there? Any company providing this measurement of IPP?
Probably so.
Now, may I come in? There is no dedicated company which gives the measuring, but we can use the compartment measuring, that is the manometric system. And the other thing from neurology department, what they are using is the brain pressure measuring. That chip on tip we can use. That's just by the side of the ureteric catheter. Yeah.
Thank you, Dr. Chakraborty. So we are going to the next presentation by Dr. Saptarshi Mukherjee, who is a young neurosurgeon. He is the HOD of the USI Medical College of Kolkata, and is doing a lot of prone and supine PCNL both. I am inviting Dr. Saptarshi Mukherjee to present his topic. Saptarshi, are you there?
A very good evening. Am I audible?
Yeah.
Yeah.
Start.
So, is my screen visible?
Yes, Dr. Saptarshi.
Okay. So, thank you for this opportunity. So, I would like to keep my presentation very crisp and very practical oriented. Regarding the basic trip of any surgery, we need to understand when to choose that particular surgery and when not to choose that particular surgery. That is very important. The same is the case with supine PCNL. The advent of supine PCNL actually was marked by its advantages from the anesthetic point of view more. That is, a patient with gross cardiopulmonary comorbidities, patients with morbid obesity, restrictive lung diseases. In those cases, a supine position did have an edge. Also, patients with significant risk of dislodgement of tubes, like in patients with anatomical or skeletal deformity, change of position can also pose those traits. Anesthetists favor this because it's having an easy vascular and airway access in these cases. Moreover, supine PCNL patients have a minimal risk of hypothermia because of dripping of the water, especially from the lateral side, mainly attributable to the positioning and the subsequent steps of the supine PCNL, which will be discussed by me in my later slides. But we, as neurosurgeons, are concerned about the urological issues. So, are there actually any cases where supine PCNL can have an edge, or there is no way to learn or no scope of learning supine PCNL? So, from my perspective, I think there are few cases, like just look at this upper ureteric calculus. This is perhaps one of the most endourologically deceiving sort of cases. Be it with flexi or semi-rigid, you sometimes may not be able to reach the stone also. And even if you do reach, there is a significant chance of retropulsion. So if you are conversant with supine PCNL without any change of position, you can go ahead with this surgery. Secondly, as discussed previously, cases with multiple calyceal calculus, partial or total Staghorn cases, where actually you are contemplating not to have multiple punctures, ECIRS have come up as a boon, and supine PCNL is one important component of that. Also in cases where concomitant procedures are required, just like in this forgotten DJ stent, where both the coils have turned into stones along with ureteric encrustations. In that cases, you can carry out the surgery concomitantly, especially if you have got two surgeons. Supine can have an edge here. Also, patients with bladder stone, lower ureteric calculus, supine PCNL can be carried out without altering the position of the patient. RIRS, sometimes we need to go sheathless. In those cases, if you are conversant and confident in the supine puncture, you can have a ultrasound guided supine puncture of the PCS to maintain the lower PCS pressure. So what I perceive, these are few cases where if you do learn supine, it can be of significant value. Now, let's come to the actual techniques. Position of the patient and the surgeon. I really can't overemphasize how important the positioning of the patient is in supine PCNL. So what we use in our setup, we can actually say it is a modified version of the Calcutta position of the supine PCNL, as has been popularized by our very own Dr. Sunirmal Choudhury, sir. So here actually I'm describing a case with left-sided nephrolithiasis. As we can see, the ipsilateral leg is completely flat and is placed on a separate trolley, whereas the right leg or the contralateral leg is placed in a lithotomy position. The ipsilateral arm is placed very casually on an armrest, as we do place in renal positions of lap or open cases, with a minimal tilt of around 10 to 15 degrees. We go for a flank-free approach. As you can see, a significant space is there beneath the flank, and this can easily be achieved by placing two hipped-up mops or some sort of bed sheets underneath your shoulder blades and one underneath the buttocks. This significantly helps the nephroscope navigation and manipulation in your subsequent steps. Now, why this tilt is so important? As you can see in this picture, if the tilt is slightly more on the right-hand side of the screen, we can see this sort of an Shyam picture can come up. What happens? There is a sort of overlapping of the renal shadow, the RGP picture or the stone with the vertebral column. This can actually interfere with your subsequent process. Similarly, if the patient is more towards the edge or more flat, again, a similar picture like this can come up, mainly due to the radio-opaque tables coming in view. So all these can actually interfere in your further process. So optimal tilt and distance from the edge is significantly done. What I do, I use the flat of my palm and I perceive that it should actually graze the flank of the patient and the side of the table just to ensure an optimal distance from the edge. And the tilt of the patient, as I have already described, should not be more than 10 to 15 degrees and can be easily achieved by placing the bed sheets underneath the shoulder blades and the buttocks. Now comes this thing. As you can see, why we do this, you can easily manipulate this leg like this. Why is it important will be described by me in my later slides. So you can keep the contralateral arm from the anesthesiologist for their manipulation, IV access or anything like that. In what we do in supine PCL, and unlike in prone PCNL, we do the draping completely at the outset. It's completely done. So you can carry out your retrograde access, RGP, ureteric catheterization, etc. And you can just come back and sit at your driver's seat comfortably. This will ensure a minimal OT personnel. You can keep a more floor space and have much less chaos in your OT. Now, once you sit, yes, you should sit in supine PCNL because it's very difficult to carry out supine PCNL in standing position, because we need to understand in supine PCNL, we are actually looking up towards the kidney, whereas in prone PCNL, we are actually looking down towards the kidney. So it's important, depending upon the height of the surgeon, you should adjust the height of your chair. But what I would recommend, keep the height of the OT table at its maximum so that you can have a good smooth angle for your further manipulations. And as you have previously seen, I normally tend to keep my side tables, the instrument tables beside me, just to be Atmanirbhar, not to call out for the instruments. So just come back to your seat, be calm. Whenever you require some instruments, just turn around and you can handle the instruments quite comfortably. Moreover, the OT sister can stand in between the two legs quite comfortably for any sort of retrograde manipulation. So it becomes a quite serene sort of environment while during supine PCNL. Not only the position of the patient and the surgeon himself, the position of the assistant will also matter, because sometimes he may need to introduce the laser fiber or the lithoprobes. In that case, if he is standing or is in an awkward position, there can be excessive bending or even breakage of the instruments or the laser fiber. So make sure your assistant sits beside you and is at a lower position than you, as you can see in this picture. Now coming perhaps one of the most important parts, marking. So marking in supine PCNL comprises of the posterior axillary line. What I do the marking in erect posture of the patient. Many people do that with supine posture or lying down of the patient. Why it is so? Because we need to understand this posterior axillary line is a sort of line between the posterior axillary fold, a vertical line being dropped on the iliac crest. But as we can see in this picture, when a patient is actually standing with his arms by the side, the posterior axillary fold is at one position. But when he lies down, the posterior axillary fold actually moves a little bit anteriorly. So in this picture, you can actually appreciate the difference between the two lines. So as far as I am concerned, I prefer to be on the posteriorly placed posterior axillary line, which I draw in the erect posture. So in this way, you can have a balance between your safety and can have an adequate space for your nephroscope manipulation. Now coming to perhaps the most important step of any sort of PCNL, that is the puncture. The first thing, decide the angle and direction of the needle. And how you can do it? Quite comfortably by putting the needle on the anterior abdominal wall with the Shyam view. Just keep the needle aligned with the calyx. Once this is done, retrace your needle back towards your posterior axillary line, which you have drawn. Here comes the important or the interesting thing. Unlike in prone PCNL, don't worry about any sort of complex calculations, any sort of angles, any sort of points. Just keep your needle aligned along the direction of the calyx, but parallel, almost horizontal with the OT floor, and go in. In majority of the cases, you will go and hit the kidney. This is the magic of supine PCNL. In cases, if you are not specifically on the target, then comes the role of your Shyam interpretation. Let's see that. So from this picture, with the Shyam in 0 degree, I can see that I am on the target. But interestingly, where I am on the anterior abdominal wall. So let's rotate the Shyam towards the head end of the patient. A minimal of 15 to 20 degree will also suffice. So what happens? As we can see, the needle has come down. So here comes the mnemonic N for N. So if your needle comes down, you are actually anterior or a bit superficial, and adjust accordingly. It's just the opposite for the posterior part. Again, as you can see, the needle is on the target, but actually I am just posterior. So again, rotate the Shyam, and as you can see, the needle has gone up. So again, P for P, that is up, means posterior, and you are a bit deep. So N for N and P for N, P. So just remember these few things and you are done with the precise puncture of the PCNL. And in supine PCNL, actually, you can have a better appreciation of the renal movement of the kidney, and you can enter the system properly and place your guide wire. Now coming to dilatation. Dilatation, follow the same principles as we do in our prone PCNL. Go for a corkscrew movement, and you can do that if you have maintained the proper angle. Otherwise, it becomes very difficult. In some cases, people often complain of excess mobility of the kidney. So you can actually fix the kidney by placing your arm on the anterior abdominal wall, as shown by the arrow. Now comes the interesting part. Often, the most difficult part in supine PCNL is the lower calyx puncture. And in obese patients, this excess pair of fat on the lateral aspect of thigh and hips can cause some sort of hindrance. So here comes the importance of our position. So when actually you can move like this and you can adduct the limb away, so you can actually gain some significant space to carry out your dilatation, and that will also help in your further nephroscope manipulation whenever you are contemplating lower calyx puncture. Coming to nephroscopy, the thumb rule is be comfortable in supine PCNL. So follow the steps as I have already described. Be seated. Ask your assistant to sit, maintain all the positions, and carry forward. Focus on fragmenting the stones. Don't be finicky or panicky about removal of the stones, because supine PCNL have got a natural tendency of gravity-dependent drainage. You did not take out the stones like this. this will help, it will be helped by the gravity. So this is a very interesting concept in supine PCNL. Just focus on fragmenting the stones and the rest will be done by gravity. Another thing that patients or the surgeons have complained, supine PCNL, the patient actually is not getting drenched, the surgeon gets. So you can use this particular thing, what I have used over here. You can just wrap a piece of gauze over here. You can see the water is actually dripping into the bucket underneath. So you are free. You can have a dry surgeon, you can have a dry OT floor, and you can have a good supine PCNL winter month also. So once you have got a good position, good angle, etc., don't worry about the intrarenal manipulation of the nephroscope. In fact, even in an upper calyx stone, as Dr. Malay Bera sir have said, even if you have entered through the lower calyx, you can very well enter into the upper calyx, as has been described in this video. So this is also the beauty of supine PCNL. Regarding degestenting, you can carry out in an antegrade fashion as we do in our prone PCNL, but sometimes we often get stuck. DJ is perhaps not going like that. Don't worry, just come back to your previous position without altering the position of the patient, and you can go ahead with your retrograde degestenting also. So these are the basic tips and tricks. So at the conclusion, I would say that master the gradual descent technique or the triangulation technique or the monoplanar technique in prone PCNL, and then you can start with apparently easy cases. And if you have got a judicious case selection where you really think supine PCNL can benefit the patient, it can be a very strong weapon in your armory or in your endourological weaponry. Thank you very much.
Thank you, Saptarshi, for an excellent presentation. I want to ask one question.
Yes,
how do you move the Shyam? It is anterior posterior direction or craniocaudal direction?
I move it craniocaudal. As I've shown in the video, that I move it towards the head end of the patient. So the mnemonic that I have devised N4N and P4P is actually for the cephalic position. Otherwise, it will change.
But do you agree that in complete supine position, like Calcutta position, you can move the Shyam also in anterior posterior direction also? Like
that you can
like
also do.
Position.
That can also be done. That can also be done.
And second thing is that in supine PCNL, there is always a collapsing or collapse of system is there. You can see that system collapsing. So how we manage this phenomena?
You can actually increase the height of the irrigation system. That is one important thing. I tend to avoid any sort of pump systems over here. Another thing is that just withdraw your nephroscope a little bit. Just withdraw your nephroscope a little bit, you will gain a bit of more space. Suppose you are within a calyx, there is chance of more collapse. So just withdraw. I had that video, perhaps it got deleted. I wanted to show that also. So you can just withdraw your nephroscope a little bit. You can gain a little bit of space. Just wait, be patient, let the system fill up for some time, and then you can just go ahead. So supine patient is the key word, I think, is patience. Then it's a very smooth and a very good surgery, I think.
Thank you, Saptarshi. Let's move on to the next presentation by Dr. Chakraborty. He is concerned neurologist in Apollo Hospital, Guwahati. He is doing supine PCNL for past many years, and one of my inspiration of doing supine PCNL.
Yeah, thank you, Sunirmal.
I invite Dr. Chakraborty.
Yeah, thank you to the ICU members for giving me the opportunity. So let's some of the techniques and the pitfalls as well as troubleshooting has already been discussed by Dr. Saptarshi Mukherjee. Thank you. Thank you, Saptarshi. Now let us, can you see the, screen?
Yeah.
Yeah, supine PCNL. Let me just discuss about the difficulties. Now, what's great about supine PCNL? In COD, COPD, orthopedically challenged, this has already been discussed. And from the anesthesiologist aspects, surgeons as well as cardiologists, this is a very good position. And actually, supine PCNL has been developed due to all this type of patients who need anesthesiologist's care, cardiologic help, or something like that. It's technically demanding, no doubt. Use of ultrasound in addition to fluoroscopy is helpful, but that's not available at all centers in India, and the required specifications. Now, whichever position the surgeon choose, he or she must become an expert in it. Now, let's move on to some timelines. Let's see, in 1980, the PCNL has been performed the first time. after 7 years, Professor Jose Gabriel Valdivia, he started the first supine PCNL, which was at that time was considered that is the PCNL done in the natural supine position and comfortable position. However, if we see that after almost 20 decades, we are still struggling with the position. Now, why PCNL, supine PCNL? Because all cases are not suitable for prone positioning. As I have already told, lung function, there is some derangement when the patient is on prone position, and there is low cardiac function also. So these things can be rectified, as well as anesthesists and cardiologists have a good access in supine position for some specific risk group patients. Now, first, let us discuss about some potential advantages which we all know. That means it saves time. That is controversial, as we have seen in Dr. Saptarshi Mukherjee's moving limb here and there to make the more space, and no repositioning and no reprepping, no redraping, no scruff, rescrubbing, no regowning. Simultaneous retrograde and calyceal puncture by 2 surgeons can be done. Less requirement of repeated nephroscope insertion. So these are definitely the plus points of supine PCNL. No issues. Less risk of colonic injury, less radiation exposure, better ergonomics, already been discussed. Reduced risk of sepsis because intrarenal pressure is less, that is theoretical again. Simultaneous tackling of renal and ureteric stones. Another thing came here, ECRIS. PCNL plus flexible URS, high SFR rate without multiple punctures. To sum up the good things, no change in position, no draping, low PCS pressure, low reverse sepsis, surgeon site ergonomically better, ECRS possible, simultaneous bilateral endoscopic possible, obese patients, high risk patients, better choice, low colonic injury, low pleural puncture, and easier upper calyx access through the lower calyx. So these are again the lower point is a theoretical one. Let us come to the points now. Adoption, how many urologists adopt this position throughout this last 2.5 decades? 20% urologists only use supine PCNL. I'm coming to the points next. In Indian context, both CRM and ultrasound is required. Plus a second team is required if we need a ECIRS to save time actually. And urologists' reluctance to take on the supine position. This why? Mentors are usually prone PCNL performers with high success rate, and changing position is not cumbersome for conventional PCNL. So these are the things we need to keep in mind while move on to our supine PCNL. Although it's not a argumentative lecture, these things are important because most of our mentors and we all first become expert in prone PCNL before moving on to the supine position. Now in supine position, if we see from 1987 to since 2023 Calcutta position, original supine position, Galakadao, then Bart's flank free approach, still most commonly utilized Bart's flank free approach. Why so many positions for supine PCNL and still the positions are evolving? Now why has PCNL failed to gain popularity in the last 35 years? The possible factors are convenience, whether it is cumbersome, learning curve is more, reproducibility is question, and stone free rate for any stone burden. It's not applicable to all stone burden. Now let's come difficulties. Some of the difficulties has already been discussed. Now reduced working space. Now all these positions we are changing throughout the years is to find out a good working space for us, which will not clash with the table, clash with the bolster, or clash with the table sidebars. Now optimum position is still evolving. Original Valdivia position with bolsters. Now with the flank free approach, this green are to the two bolsters, in between is the flank free. But how much flank free? Still there is space problem is there. Now another difficulty, complex puncture. Let's come to the puncture. Only putting a needle and aspirating urine is not our ultimate aim. The basic principle of PCNL should be kept in mind. Shortest tract, a concise and precise puncture through the posterior calyx, and through a position of the tract should be such that our nephroscope can be easily maneuverable within the PCS. And specifically when after breaking a stone fragment, the stone fragment we have to chase sometimes. So posterior, these things are already been discussed. Posterior axillary line, horizontal puncture, fluoroscopic guidance, ultrasound guidance, the techniques. Now, how to puncture? Bullseye not available. Now, we have to depend only on two, that is the triangulation technique and not gradual descent technique. Here is the gradual ascent technique, not the gradual descent technique. And ultrasound, if there is in the OT, in the Indian context, it's the best thing. We have can check our position where we are. Now, complex puncture technique, again it goes into, unlike the prone position, the needle must remain almost horizontal and slightly inclined upward towards the operating table. The puncture site was marked at the level of the posterior axillary line at the level of the 12th rib. The markings has already been discussed. Now, after puncturing, this next question come, am I in the posterior calyx or unfortunately I am in the anterior calyx? The bars modified or whatever position you use, we need to remember that the pelvis is in the almost in the horizontal position and the upper torso is torque almost 90 degree. So in that position what happened? The rotation of the kidney happens. The calyces we see, sometimes we make a puncture thinking it to be a posterior puncture along the right avascular plane, but actually it is in the anterior calyx. So most often or not, for the initial beginners, we end up in putting our needle in the anterior calyx. And when we realize that the stone is not visible, water is coming, everything is good, we have made dilatation, but then we put a second puncture to place in our needle in the posterior calyx. So that problem always happen. So this is in the anterior calyx. There is a good puncture, everything went well, but anterior calyx, and we have to change the position. Now, puncturing anterior or posterior calyx is again here diagrammatically it is shown that anterior calyx and posterior calyx, whenever we enter the anterior calyx, it is severely our mobility is restricted. It is colliding with the side table, here sidebar, and anteromedial movement is more common with supine PCNL. So risk of more trauma to the parenchyma during the dilatation process. Now, puncture and dilatation, another problem already been discussed by Dr. Saptarshi is the spinal interposition. Now, as the kidney is more mobile in supine position, sometimes there is spinal interposition and the whole PCS with the dye inside contrast superimposed with the, so there is chance of medial pelvic injury while dilatation. Reduced nephroscope mobility clashing with the OT table and bolster and iliac bone. There are three things here. One is OT table, one is bolster, and third is the iliac bone. So our space, the window of mobility is very, very restricted. So we need to choose very, very specifically which patient we have to do and which patient we don't have to do. So, and often chasing a stone fragment is difficult. The OT table sidebar and the iliac crest are the main limiting factors for the nephroscope mobility. And then we end up with, oh, move this one, move that one, move our limb, move the C-arm and the body to some and to little bit more laterally or medially. So these things will start. Table sidebar interposition. Now, this is the table sidebar interposition, what we are thinking, and it's really a very, very irritative symptoms during the supine PCNL. a special table which is translucent without sidebar, and moving the C-arm is not helpful. So a special table is usually useful who are already performing supine PCNL regularly. Now next, dilatation technique. Now complex dilatation process and too much mobile kidney. Now, when the kidney is too much mobile, the dilatation is difficult. Number one point is that a longer tract is required. Shortest tract is not possible. Always a longer tract. More mobile kidney within the retroperitoneum that needs stabilization with a hand put anteriorly, or we can do another thing, throw and throw guide wire. We see the guide wire and pull it through the, and on the both sides through the urethra as well as from outside, fix it the guide wire, and the needle will be little bit, kidney will be little bit stabilized. Larger tract may limit the nephroscope mobility and more torquing on the parenchyma. Risk of medial injury and perforating the medial pelvic wall is more common. Now, suggested solutions already we have discussed: through and through guide wire, assistance abdominal compression, place a ureteral access sheath, and in retrograde fashion with continuous irrigation so that the PCS remain dilated to some extent. Single step dilatation is better. Sequential dilatation will not help because sequential dilatation will drain the whole irrigant and decrease the caliber of the ampullus sheath. There should be a balance between the nephroscope and the ampullus sheath diameter to match without much irritant leakage so that the PCS remain little bit dilated. In
Dr.
obese
Chakraborty,
patients,
I think you have to conclude your presentation.
Yeah, sure. Long tract length, need extra long ampullage, need an extra long nephroscope. Now, fragment migration due to reduced flank space and nephroscope mobility, and fragment migration and chasing is difficult. Flexible ureteroscope should be used. Second puncture may be necessary. ECRS, RIRS may be helpful. Longer PC tract is problem. Now, contraindications are same. Let us come to our concluding slide. Sorry. Use of ultrasound in addition to fluoroscopy is mandatory sometimes if available. Which position the surgeon choose, it is essential that he and she become an expert in that position. Without becoming an expert in prone PCNL, supine PCNL cannot be mastered. This is the right thing one should keep in mind, I think. And one supine position doesn't fit all, and the right one must be chosen for the right patient and the right stone burden. We should familiarize with the both supine PCNL and prone PCNL and fit the technology procedure to the patient and the stone. We should not do it just because we can. So this is my experience and what the evidences tell about this supine PCNL. Thank you. Thanks.
Thank you, Dr. Chakraborty. I think we have discussed a lot of supine PCNL now. I am going to straight to the next presentation. That is Dr. Nabankur Ghosh will present next. And he is a consultant neurosurgeon. He has already done over 3,500 PCNL and doing lot of PCNL cases and presenting all over the India. And I am calling Nabankur to present his presentation. Nabankur, please.
Yes, just a minute.
Nabankur, start your presentation.
Is my slide visible?
Yes.
So good evening, everybody. Good evening, everybody. Thank you, ISU and Dr. Sunirmal Choudhury for giving me the opportunity to present my experience of doing PCNL in anomalous kidneys, the tips and tricks. Let's have a quick recapitulation of our embryology classes. Between 6 to 9 weeks, kidneys develop, and as they develop, they also move up from the pelvis up to the normal anatomical position. As they move up, they also rotates medially so that the pelvis, which was originally facing anteriorly, now becomes more medial. And as the kidney moves up, it also receives a series of lateral sprouts from the dorsal aorta. The final one matures as the renal vessels. The axis of the kidney, as we know, it passes from the superior pole to the lower pole, makes an angle around 30 degrees with the horizontal plane. World over, the incidence of anomalous kidney ranges from 3 to 11%, and there is always an increased incidence of stone formation in anomalous kidneys due to impaired urinary drainage, due to abnormal anatomy like PUJ obstruction or high insertion of the ureter. PCNL, as we know, is the gold standard treatment for treating stones which are located in the kidney and upper ureter, particularly for large and complex stones. But PCNL also confers some unique challenges in anomalous kidneys. Not only there is abnormal anatomy and orientation of the calyces, but also there is an increased risk of damaging the surrounding viscera and aberrant renal vessels during the procedure. Now, various classification systems exist in literature of anomalous kidneys, but this is a very practical and crisp classification. The rotation anomalies of the kidney, mainly the malodate kidneys, kidney with duplex system, fusion anomalies of the kidney, of which we'll discuss two particular varieties, the horseshoe kidney and crossed fused ectopic kidney, and ectopic kidney, of which pelvic ectopic kidney requires special mention. Once again, various rotation anomalies have been described in the literature, but the most common is a simple malrotation, which often comes as a on-table surprise during RGP if PCNL is done on basis of an X-ray or ultrasound only. And that's why we require a good quality preoperative imaging in the form of IVU or CT urography to prevent such awkward situations. Now, in malodate kidneys, the calyces are rotated either too medially or too laterally. So we need to adjust the initial puncture site depending on the orientation of the calyces. Sometimes we have to move more medially, very close to the vertebra, or sometimes we have to move very laterally, very close to the posterior axial line, depending on the orientation of the calyces. And one popular technique is entering through the roof. I shall explain what is meant by this entering through the roof concept. Now imagine kidney as a room. So just like a room, it has lateral walls, roof, and floor. In malodate kidneys, the lateral calyces, they are rotated either medially or laterally. But the roof, that is the superior calyx, which is a complex calyx, almost remains constant. So whatever the orientation of the calyx is, medially or laterally, the roof remains constant. So if we enter through the roof, the superior calyx, we can virtually go almost in each nook and corner of the kidney, except a few upper middle calyx. Duplex kidney has two ureters coming from a single kidney, and these two true ureters may drain independently into the bladder, or they may connect with each other at a variable distance from the PUJ to the VUJ, and as a single ureter drain into the bladder. Duplex kidney can occur in one or both kidneys. Now there is a wide variation of duplicity of the kidneys. For example, it may be a simple bifid pelvis, but the two pelvis, they unite to form a common pelvis and drain through common ureter into the bladder. Or it may be a complete duplication where the two kidneys, two moieties drain with independent separate ureters and into the bladder. This is an example where PCNL was performed in duplex kidneys. In case 1, the stone was located in the superior calyx of the upper moiety, which was very high. It was supra 11th. On case 2, the stone was located in the middle calyx of the lower moiety. It is very important to accurately localize the stone before doing RGP. Where the stone is, in which moiety and in which calyx. Because if the stone is in the superior moiety, there is no way by which you can go to the superior moiety by puncturing and entering the lower moiety. Particularly in cases of complete duplication, always look for the ureteric orifices, because sometimes in complete duplication, the upper moiety ureter drains in an abnormal position location. It may be anywhere in the bladder or even in the prosthetic urethra. Always place the ureteric catheter in the stone-bearing kidney. Otherwise, it may be troublesome for you, particularly for prone PCNL. I am trying to explain this by a simple line diagram. This is a duplex kidney where the stone is situated in the lower calyx of the lower moiety. Now, if you try to push the guide wire, and over the guide wire, you could try to push the ureteric catheter, it will invariably go into the upper moiety. In that position, if you do the RGP, all the contrast will go into the upper moiety and opacify the upper system, while the lower system will remain completely unopacified. So sometimes you may require the help of a ureteroscope to guide the guide wire into the lower moiety, and over the guide wire, you can pass the ureteric catheter. Now, suppose this has happened in a case where patient has already been made prone. And then you see, you're supposed to put the guide wire in the lower moiety, you put the guide wire in the upper moiety. In incomplete duplication, you still have a chance without turning the patient again into the lithotomy. You just pull the ureteric catheter slightly in a small steps under Shyam guidance up to the point where the ureter bifurcates. So if you inject the contrast in that position in a larger volume, the contrast will flow in both the moieties and both moieties can be opacified. However, in case of complete duplication, you have to reposition the patient and you have to put the guide wire in the correct ureter and the correct moiety. Once again, various fusion anomalies have been described in the literature, but of which the most common is the horseshoe kidney, which occurs in roughly 1 in 600 live births. In this condition, there is a fusion of the kidneys at the lower pole, forming an isthmus, which leads to failure to ascend because the isthmus gets stuck at the origin of the inferior mesenteric artery. The kidneys cannot rotate completely, so there is malrotation of the kidneys, and there is high insertion and lateration of the ureter, leading to impaired drainage from the collecting system. Also, there is high incidence of kidney stones among adults with HSK. This is an example how PCNL was done in horseshoe kidney. The stone was located at the middle calyx of the left moiety. The stone, after RGP, the middle calyx was punctured. It was sequentially dilated, and the stone is removed. This is another case where the stone is situated in the left moiety at the pelvis, where the upper calyx was punctured and the stone was removed. Now, contrary to popular belief, PCNL is actually more simpler than a normal kidney because there are two advantages of HSK in PCNL. Number one, the kidneys are always situated at the lower position compared to the normal kidneys. So access to the upper calyx is easier and with less complication compared to a normal kidneys. And number two, even if there is no PUJ obstruction, there is always some degree of permeabilization dilatation. The calyces are wide open, the infundibula are wide open, calyces are dilated. So if you enter through the upper calyx, you can virtually reach almost all portions of the kidney. The second most frequently observed congenital malformation is the crossed fused renal ectopia, which occurs in nearly 1 in 1,000 to 2,000 autopsies. They are slightly more common in male. Here, an ectopic kidney crosses the midline and merges with the orthotopic kidney of the other side. Left to right crossover is more common. Interestingly, the ureters are inserted in the normal position into the bladder trigon. That means the ureter of the lower moiety has to cross the midline to get inserted into the bladder. In my short career, I have there are 6 primary categories of this entity, of which unilateral fused kidney with inferior ectopia is more common. And there is higher incidence of stone formations, like all congenital anomalous kidneys. In my short practice, I have encountered 2 such cases of cross-renal ectopia where PCNL was done. In the first case, the stone was situated in the superior calyx of the inferior moiety. Now, this is technically a little bit difficult because the superior calyx is the lower moiety is just like the mirror image of the upper moiety. So the medial surface is actually lying laterally. And so if you want try to enter through the lateral surface of the kidney, externally, the puncture site become very close to the margin of the vertebra. Fortunately, I got a safe site through which I can enter into the upper calyx of the lower moiety. This is the RGP which shows opacification of the both system purposefully to demonstrate. The another important point I want to highlight for doing PCNL, particularly for the lower moiety in cross-renal ectopia, the lower kidney is actually situated very deep. So whenever you attempt PCNL in such cases, always be prepared with an extra long amplux sheet, because sometimes it may happen that your complete amplux sheet get buried up to the margin of the skin margin. This is the second case. Here, this is comparatively easy because the stone was situated in the upper calyx of the upper moiety. The pelvic ectopic kidney occurs in roughly 1 in 2000 or 1 in 3000 autopsies. The ectopic kidneys are most susceptible to calculi and hydronephrosis due to impaired drainage. And this is due to the anterior position of the renal pelvis, the malrotation of the kidneys, the high insertion of the ureter, and anomalous renal vasculature. The unique problems of doing PCNL in such cases that the kidney is not only low down, but also rotated anteriorly. Posteriorly, it is guarded by sacrum, so there is no way by which you can enter through back. The only way is to go from front, anteriorly, where there is a peritoneal sac containing gut loops below the abdominal wall. So during PCNL, laparoscopic assistance is essential to avoid injury to the bowel and anomalous renal vasculature. This is a patient who have a left-sided ectopic pelvic kidney with a comparatively large stone at the pelvis. So 2 surgical teams with separate innovation camera and monitors are required. Retrograde uric catheter was inserted in lithotomy position. The patient then placed into supine position. A 10-minute umbilical port was made for camera. 2 5mm ports are created, one in the left mid-clavicular line and one in the left iliac fossa. This is a short video to demonstrate the procedure. This is the ectopic left kidney showing as a bulge. We slightly deprioritize the kidney, but although it is not necessary, but we want to see the renal vasculature also. Then under laparoscopic guidance, the pelvic system, the upper calyx actually, it was punctured. Then the tract is sequentially dilated. Now, it is very important during the dilatation that you tract the guide wire should be absolutely straight, because unlike the standard PCNL, where there is supporting retroperitoneal tissue to prevent that buckling of the guide wire, here there is nothing but air in the peritoneum. So if your guide wire gets bent somewhere, it is very difficult to make it straight once again, and your whole process will be lost. So be extremely careful while in the dilatation process. Thank you for a patient here.
Thanks.
Thank you, Nabankur. I have one question. What position do you think preferable in case of anomalous kidneys, prone or supine?
I think for anomalous kidneys, prone PCNL is the safest. But for pelvic kidneys, you have to make the patient supine. Otherwise, it is not possible.
Okay, thank you. Thank you, Nabankur. Let us go to the next presentation by Dr. Krishnendu Maiti, who is Professor of Urology in IPGMR SSKM Hospital, Calcutta. He has got keen interest in pediatric PCNL. So without wasting time, I am inviting Dr. Krishnendu Maiti to present.
Thank you. Is my skin visible?
Yes, Krishnendu. You can start.
Yes. Thank you, Sunirmal. Let's thank the Indian School of Urology. Now, my topic is pediatric PCNL, challenges and solutions. Nowadays, pediatric stones are more commonly they are diagnosed, maybe because of easy availability of the ultrasonography elsewhere in any parts of the country. As a general principle, ESWL or nowadays is the RIRS, stented RIRS is the mainstay of treatment for smaller volume stones in case of pediatric patient, and for larger stones, PCNL is indicated. One thing we have to remember that pediatric patients are separate both anatomically because their kidney smaller and both physiologically also because physiological parameters are different from adult patient because in a 10 or 15 kg boy child with 100 ml blood loss would be a very much complicated physiological parameters in comparison to the adult patient. So that we have to keep in mind. Now, what are the indications of pediatric PCNL? Usually the stone size more than 20 millimeter or a partial or staghorn. These are the standard indication for pediatric PCNL. And smaller stones, that is 10 to 15 millimeter stones with lower pole or unfavorable anatomy like calicial stone, diverticular stone, where RIRS could be difficult. And where the failed RIRS or ESWL cases and stone with pelvic junction obstruction. These are the main indications. Now, what are the challenges? As I've said, they are anatomically smaller kidney. So you have to be very precise. Pediatric PCNL is not a operation that should be done by the novice. Only the experts should venture pediatric PCNL because here, once there is complications, it's very, in case of adult, we can easily manage. If there is bleeding, you can manage it with angiographic embolization. But in pediatric patient, and angiographic embolization is a hell of a job. So that we have to keep in mind. It's not that the operation by the novice should be done by the novice. And second thing is that chance of bleeding because of perforation, narrow calyces is much in comparison to the adult patient, and radiation. Because these patients, these childs are very much prone to radiation injury consequences. So radiation should be kept as low as possible. And here working space is limited. So heat generation is much more, although we are using LED light source nowadays, but still heat generation is more. And when we are keeping the child in prone position, this airway management positioning is an issue in pediatric patient. And in pediatric patient, if you are using any higher intrapelvic pressure, so chance of complication, sepsis, transmigration of the normal saline into the peritoneum, these are much higher in comparison to adult patient. Now, to overcome the challenges, what precaution we can use? Because in comparison to the adult patient, pediatric patient is having almost same retrorenal
incidence of retrorenal colon. So during puncture, what precaution or advantage, what precaution we can take? We can take the advantage of the ultrasonographic guided puncture. It has two important advantages. One is we can avoid the retrorenal colon injury, and second is that radiation exposure can be minimized by doing this ultrasonography guided puncture. Now again here, the standard convex probe that is too big for a child because the surface area is too big for the convex probe. So here the linear probe is better option, and preferred like any other PCNL, preferred site of puncture is the posterior lower calyx. And the precaution, as my previous presenter had already described, it is the mini nephroscope and mini tract size should be the norms in case of pediatric patient. And single step dilatation is preferred because from the skin to the target pelvic cell system, the distance is very small. So sequential dilatation would not be a very good. Here, the single step dilatation is ideal. And tract size in pediatric patient, smaller the tract size as a whole, the less chance of bleeding, because bleeding, once bleeding occurs, pediatric patient, as I've said, the physiological parameters is such that our aim should be minimum bleeding, blood loss. So mini nephroscope is preferred, maybe ultra mini. My previous presenter already said that mini means less than 20 French, ultra mini that means in between the 11 to 30. And most important thing, as I have said, the radiation, because the children are more sensitive, higher lifetime cancer risk. And to decrease this radiation, we can use the ultrasonography guided puncture to reduce the fluoroscopic time. And during use of this fluoroscopy, we must be use it pulsed, not continuous. And collimation with the help of lead seal. The newer fluoroscopic machine is having collimation. You can block the field area by this lead seal so that only the target area will be exposed. That will decreases the radiation to the child. That is very important. You can collimate half of the field, 1/4 of the field in newer machine. That is very important. And last, image hold. That's also important. That will decreases your use of fluoro. And one thing you must keep in mind that in adult patient, usually the alarm is set for 5 minutes, 300 second fluoroscopic your thing. But here in pediatric patient, your fluoro times target should be less than 60 seconds. So to decrease this fluoroscopic time, ultrasonic guided puncture is a better alternative. Bleeding, usually in most of the cases, it is the 1 to 2 gram per deciliter decrease of hemoglobin. Transfusion, 2 to 3%. Miniature the tract, less chance of bleeding. Single step dilatation, as I have said, and low intrapelvic pressure should be used. And as my previous presenter said, suction sheath is better. If we should in no circumstances uses pressure during this flow of the fluid, because if you are using high intrapelvic pressure, the chance of pilovenous flow, fever, sepsis is much more. And like any other PCNL in pediatric patient also, sterile urine is a mandatory. And if there is any after puncturing, there is pus, abandon the procedure. Okay. And early recognition of the sepsis when during the procedure, if there is tachycardia or hypotension, to abort the procedure. Positioning both prone and modified supine. The previous presenter said that flank free supine, modified supine is also acceptable. But one thing is that choose the position, whether prone or modified supine, according to your expertise. If you are expert in doing the prone, do it prone. If you are expert doing modified supine, go for that. Okay. So safe procedure is important, not the position. It is being in the literature that nowadays prone PCNL in pediatric is comparable with the frank free modified supine procedure. The instrumentation, mini nephroscope, 11 French, this Olympus or 12 French storage is the most commonly used instrument for pediatric PCNL. Pelvic pressure should be less than 30 centimeter watt. That means 1 feet above the height of the table, not more than that. And usually use the degestenting tubeless in selected cases. Now, as I've said, that mini PCNL, the indication is more than 2 centimeter, 20 millimeter stone. And that is the standard indication. Ultra mini can be used for lower calicial stone of 1.5 centimeter or calicial diverticular stones. And the outcome of the pediatric in an expert hand, the stone-free rate is 85 to 90%, that of the adult patient. The complications is also as per the adult patients, and transfusion is, as I've said, 2 to 3%. And infants are safe with the small attacks. Never use standard PCNL and standard sheath in case of pediatric patient. Now, when not to do PCNL? Or what are the contraindication doing pediatric PCNL? Like any other PCNL, active infection and bleeding diastasis. That is absolute contraindication. Most of the stone size 15 to 20 millimeter, try to adapt ESWL or stented RIS, because that is the safety range is better than in comparison to the PCNL. Post-operative care here in the post-op day 1 ultrasonography should be protocol to show if there is any collection, perinephric collection, or if there is, you should be vigilant about the fever or flank swelling, because as I've said, pediatric physiological parameters are something different from the adult. So the take-home message is that sterile urine is a mandatory. Ultrasonography guided first access to map the adjacent organs, especially the retrorenal colon, smallest effective tract, and single step dilatation is preferred. Low radiation, as low as possible, with pulsed fluoro, collimation, and total fluoro time less than 60 seconds should be the norms. Low irrigation pressure less than 30 centimeter, and tubeless when possible. So these are my references. Thank you.
Thank you, Krishnendu, for excellent presentation. So I am going to our last presentation by Dr. Gotam Pipara, who is a young neurologist, and he's concerned neurologist at ILS Hospital at Salt Lake and Howrah. Gotam, are you there? Please go ahead.
I am here, sir. Yes. Is my screen visible?
Yeah, it's visible.
Yes, sir. So I must thank Indian School of Urology and Sunirmal sir for giving me this opportunity. And if we're going to talk about complications of PCNL today, it is a very important topic, especially for all the postgraduates. So the roadmap of my presentation is going to be access-related complications, intraoperative complications, post-operative complications, prevention and risk reduction, and case-based discussions. So this topic is actually very huge and requires a lot of discussion, but I will just try to stick to my time limit of 10 minutes. Now, quick classification table. If you look at the access-related injuries or access-related complications, we could have bleeding, pelvic perforation, adjacent organ injuries, or a failed access. That means we have not been able to form an access at all. Intraoperative, we could classify them as significant hemorrhage, an infundibular tear, or a pelvic system injury, loss of tract, or a pleural injury resulting in hydrothorax. Post-operative, the most common is fever and sepsis, hydrothorax, urinoma, delayed bleeding, or residual stones. So coming to all of them one by one, in short, I would be describing each complication, how it happens and how we can manage it, but it's going to be in a nutshell. Now, access-related complications, the first is bleeding. Now, bleeding is very common during access, and it is one of the most important complications. Now, going too medially sometimes can cause a segmental vessel injury. Multiple punctures, as you can see in this, if you're using 3 tracks, 4 tracks, bleeding is about to happen. Dilator or sheath misalignment, if you've used very big dilatation, usually dilatations more than 24 French will cause more bleeding, and there is a chance that the patient will have significant hemorrhage. Now, prevention, the calycial tip should always be that the tip of the papilla should be the target. Now, avoiding 2 medial punctures, that is more than 2 centimeters from the lateral border of the kidney. And obviously, all of us use a biplanar fluoroscopy or ultrasound guidance. Try not to make too many punctures. You make one puncture, whatever you're comfortable with, either bull's eye or a gradual descent technique, whatever you're comfortable with, try to minimize the number of punctures. Now, management is tamponade with an ampullate sheath and to complete the procedure quickly in case you are midway. Nephrostomy tube placement is usually recommended if there is hemorrhage, and you can clamp the tube. You can reopen the tube 2 hours, 4 hours later, and you can see what is happening. If it is persistent, suppose you have puncturing, and that time only you can see that there is a sputter. So you can just stop, apply some pressure for some time, wait, and again then repuncture at a new calyx or at a new position. Nephrostomy tube, as you've already said, if you are midway and you're still dilating and you can see a lot of bleeding coming out, you can just stop there, put a tube and see. Blood transfusion and SOS angioembolization. Angioembolization, especially when you're doing a access or dilatation, is rare, but sometimes you might need it. Now, organ injury. Now, the organs that can be injured are colon, spleen, liver, pleura, or the lung. Now, sometimes a gallbladder can also be injured. So there's been a case which has been reported in the conference where the gallstone was being seen on the fluorography, and Siam-guided dilatation of the gallbladder has been done. So colon, most probably this can be completely avoided if you check the CT. If there is a retrorenal colon, then we must be very careful. If you're doing a too high access on the right side, liver can be injured. On the left side, spleen can be injured. Supracostal access, pleura can be injured. So usually if you have injured the colon, a conservative management, put a stent and separate it, put a tube, colostomy means put a tube into the colon and then you can remove it later once it's healing. Colostomy is rarely required. Now, spleen sometimes, very rarely, might require embolization or splenectomy, but conservative management, both in case of liver and spleen, are usually effective. If a supracostal access has been done or the pleura and lung has been damaged, usually intercostal drain will do the job. Pelvic perforation, this can occur during the initial puncture or with a guide wire. So that is why to avoid, we must always use a soft tip guide wire. We should not overshoot. We should use contrast or air, whatever you're comfortable with. Many people will have a debate on this, whether air or contrast. But then if you're using a puncture needle, don't overshoot. Direct vision during the lower calyceal puncture, that means you must see it and then puncture. It should be under fluoro guidance, under ultrasound guidance, or using contrast. Now, how do you manage? If it's a small tear, you can just proceed and complete the procedure, maintaining a low pressure irrigation, not going too close to the pelvic place of pelvic perforation too many times. If you think that it is a large tear, then you must abort, stent, drain, and then return back after 1 or 2 weeks. Sometimes even, if you think that you cannot discharge the patient, at least after 40 to 72 hours, you might go back again. Now, failed access. Failed access, we have false tract dilatation. Now, we must always confirm that the guide wire has gone into the PCS. The best is that you can see that there's a contrast-filled PCS. The guide wire has gone in. It has gone through the PUJ across into the ureter and gone down into the bladder. Now, sometimes what happens is that the guide wire would have gone. It is going alongside, but it is not inside the ureter. As you can see in this picture, you can see that the guide wire has punctured, it has entered the calyx. So you would have got water when you've punctured, but then later this guide wire has curled and gone around the kidney. So you should be very careful that you're not doing a failed access. Here you would feel that, oh, water is coming, so I'm actually inside, but you might be dilating a wrong tract and ultimately you will not be able to reach the PCS. Coming to intraoperative complications, the bleeding mechanism could be infundibular tear, a pharyngeal tear, avulsion by a rigid nephroscope, or high pressure irrigation. So you can see here that as we are rotating the nephroscope, now there can be torque at these two places, because of which there can be vessel injury resulting in bleeding. Now, hemorrhage from collecting system or vessels. Now, what are the things that you can do? So number one, always maintain a lower irrigation pressure. Check for a mucosal tear and give time to tamponade. Place a nephrostomy tube. If it is very, very severe, then you might require urgent angioembolization. So if you see that the patient is becoming hemodynamically unstable, or there is too much of loss of blood, and the patient's vitals are becoming unstable, then you must shift the patient for angioembolization, keep blood ready, call for help. Loss of tract or sheath displacement. Now, the most common reason is that the guide wire has come out or the guide wire has not been pit. And the second most common reason is that the skin fixation of the implant sheath is not good. So therefore, the tip is that you should maintain a tactile orientation with one hand stabilizing the sheath. If it is lost early, you can do a serial dilatation again. If it is lost late, you can stop reposition under fluoroscopy, but however, you must avoid force. You can use a mini nephroscope, see here and there, try to keep passing a guide wire. Once it comes into the track, the guide wire will usually go in and it will go into the PCS. Pleural injury. So whenever there's a supracostal axis that is above 10, above 11, pleural injury might happen. If the patient is under spinal, the patient might start complaining of cough. You might notice desaturation, difficulty in breathing if the patient is in spinal. You can aspirate the fluid. If fluid or hemorrhagic fluid is being aspirated, then there's high likely chance that there has been an extravasation and the patient has had an hydrothorax. Sometimes on fluoroscopy also you can see blunting of costophrenic angles, though it also depends upon the quality of the C-arm and sometimes might not be very evident. Now, the management plan includes intercostal drain. We continue the PCNL only if the patient is stable. If the patient is not stable, then we usually abort the procedure, put in a train, we wait for the hydrothorax to heal and means completely resolve, and then we come back again. This can be prevented by staying within the lateral scapular line. Postoperative complications. Now, postoperative complication, the most important complication remains fever, sepsis, or SIRS. Now, it is most commonly seen whenever there are infected stones or a large stone burden, if we are using high pressure irrigation, and especially in patients who've got stones with emphysematous pyelonephritis. Now, prevention, you must ensure that you've got a sterile culture prior to the procedure, but many a times it is not possible. So if you see that the patient is infected, it is better to stent, put a PCN, wait for the infection to clear down, give antibiotics, and then come back later. While doing the surgery, we must maintain a low pressure irrigation and avoid too much of high pressure just to remove the stones. So many a times what we do is we give high pressure so that the stones will come out by themselves, especially the whirlpool effect, and many of the Karlstor sheath works very well. But if you see it is an infected patient, it is better not to use the same. Now, management is usually with broad spectrum antibiotics, fluids, and vasopressors. Now, sometimes we would have completed the procedure and we would not have put a stent, but then a small fragment might have migrated down, obstructing, and that might be the reason for sepsis. So sometimes we must do a CT, look for obstruction, and ensure drainage with stent or nephrostomy. Now, delayed bleeding or pseudoaneurysm, AV fistula. Now, that is arteriovenous fistula. This will usually occur between 5 to 21 days when the patient says suddenly he's passing a lot of fresh blood, a lot of hematuria, there's fall in hemoglobin, and this keeps on happening. So we do a CT angiography and angioembolization. This is the gold standard of treatment and works very well. Once we do an angioembolization, usually the patient becomes very well. Now, urinary leak or urinoma, this is usually caused because of a pelvic injury. That is, means we have injured the renal pelvis during dilatation or the stent is blocked. The management is very simple. You either upsize the stent, place a PCN, or drain the perinephric collection. Sometimes the perinephric collection can become infected and that can become a source of fever. So if we are seeing that there is a urinoma, it must be dealt with properly. Hydrothorax, this is again the most important complication and the most significant complication that all young pass outs will be very scared of. So you should be very careful when you've done a supracostal access. Just next day morning, get a X-ray done. That will give you a lot of idea. A small amount of effusion will usually heal by its own, but if there's a large effusion, you need to place in a you need to place in a ICD tube and delay. If you're staging the PCNL, then you delay the next stage until resolution. Residual stones, the causes could be anatomical constraints. You could have had bleeding. The lower calyx could be at an unfavorable angle. So whenever you're dealing with a large stool burden, it is always best to say that there can be residual stones. When you're taking a consent, we always take a consent that there could be residual stones for whatever reason. And when you're removing the stent, you could go ahead, do an RIRS, or you could stage the procedure and remove the stones later. Flexible nephroscopy also helps. And second look if there are more than 5 mm residual fragments that are left behind. Therefore, if you look at the risk reduction strategies, pre-operatively, we must do a good CT, assess for a retrorenal colon, and treat UTI. When we are making the axis, posterior calyx, papillary line, and ultrasound, fluoro, or combined axis. Dilatation, one clean puncture. Please avoid repeated attempts. In the initial days, everybody makes repeated attempts, but eventually, as you are maturing in how you puncture, it must come down to 1 or 2 attempts. Intraoperative, maintain low pressures, maintain the sheath in position. Postoperative, early monitoring for fever, bleeding, and chest X-ray for supracostal. So short case discussion, these are only just 2 and I'm going to wind up. Now, sudden bleeding intra-op, bright red arterial blood while clearing lower pole stone. What do you do? So first thing, you stop the lithotripsy, reduce the irrigation pressure. Now, usually there will be one bleeder. You pull the scope back, look at where the bleeding is from. You place the implant sheet such that the bleeding stops, place in a nephrostomy. Monitor. If the hemoglobin drops by 2%, then you need to give blood, and you keep a close watch. You unclamp the nephrostomy after 2 to 4 hours and see what is the color. You could use tranexamic acid. Now, this is again debatable. Many people want to use it. Many people don't want to use it. The second case, if the patient is presenting with hematuria on day 7, so 5 to 21 days, it is likely that the patient has developed an AV fistula. So you must suspect pseudoaneurysm, get a CT angio done, not a CECT. So a CT angio should be done and immediate embolization, and avoid blind tack reinstrumentation. Therefore, take home summary, if I look at the complication and the most important point, bleeding, you must have a good access. It can save lives. Organ injury, you must know the CT anatomy well. Look for a retrorenal colon. Sepsis, keep pressures low. Treat a culture positive patient. Use prophylactic antibiotics. In case of emphysematous pyelonephritis, stent first. Pyonephrosis with stone, stent first. Delayed bleeding, CTA plus embolization. If any thoracic issue, supracostal puncture, please get a chest X-ray next day. Small effusion can be managed. Large effusion needs ICD. Conclusion, PCNL is safe and effective when done with anatomical precision and controlled technique. A systematic prevention first approach definitely reduces all complications. Thank you.
Thank you, Gotam, for excellent presentation. Dr. Surya, it is already 9:42. So what to do? Whether we take some, they will go for presentation or
yeah,
take some.
Actually, we are, I think, getting late a bit.
Yeah.
Then maybe you can take some questions in the chat box.
Well, then we can take some questions.
Yeah.
Okay.
I had only one comment to make on Dr. Gautam's presentation. For pyonephrosis, I don't agree with DJ stenting. I would prefer a PCN to drain a pyonephrosis.
I agree, ma'am. I
also agree, madam. I think PCN is a better option, pyonephrosis.
Yes. I completely agree.
So I want to ask the Dr. Saptarshi, in a normal place kidneys, what are the contraindications of supine PCNL? When kidney in normal position. Dr. Jana Chakraborty, Dr. Saptarshi Mukherjee.
Hello. Can you hear me? Yeah, Sunirmal.
Yes.
Actually, in a normally placed kidney, we should not put the patient for supine PCNL. We should do the prone PCNL and conventional PCNL, because that gives us the most good exposure and our freedom to move through the whole of the PCS if we can choose a good calyx for entry. Only in cases where the prone PCNL is contraindicated, such as in severe heart condition, anesthetists don't like the prone position and all these things, then only supine PCNL should be addressed. So this is my take on this issue, and only because we can do supine PCNL does not mean that we should put all the patients under supine PCNL, and that's why throughout this last 35 years it has not gained so much momentum. If you see, the prone PCNL is still practiced more than 80% of the urologists. Sorry for a big comment on this.
To my take, that I find that medially placed upper calcium stone is the most difficult one to puncture in case of the supine PCNL. Medially placed upper calcium stones.
Sure.
Another question is that yes, sir.
Yeah, Dr. Sunirmal. Another point, one should be very cautious in doing supine PCNL in patients who have already undergone open kidney surgery. Because once I burned my fingers, because kidney doesn't fall medially. So somebody has undergone a pyelolithotomy or infected kidneys with previously undergone any procedure. So then there is a risk of bowel injury, colonic injury. So I prefer to doing a prone PCNL patient who has already undergone open kidney stone surgery.
I totally agree, sir, because I have got one single case of chlorotic injury in my career, and that is in operated case. That operated the kidney that was urosurgery in that case, and we entered in the colon in that case. So this is another point that in case of operated kidneys, operated any urosurgery, fast history, pylocytomy, you should prefer it. It is prone is better suited.
Yes, yes.
Another question
Yeah,
is that
I think if you have to learn PCNL and means I think I may be right or wrong, but I feel that what we can teach in 3 years of residency is very limited, and at least the student should be proficient in prone PCNL.
Yes.
Later on, they
Yes,
can go
madam.
in their life and learn supine PCNL, but
Yes,
prone
madam.
PCNL is a must skill to learn.
Yes,
Madam,
100%.
if you say like that, I've hardly done any prone in last 5 years. My residents,
No,
they
but
don't
that
know.
now you're past your MCH 10 years or 15 years ago. But during residency, I'm saying.
Yeah.
Please, like TURP, PCNL, these are skills which we have to teach and we have to master at least before we venture into further refinements.
I agree with you. I agree with you.
there is a question that in the era of supine PCNL, does the concept of assessing the posterior caries hold good anymore? So I think it's a very right question. And nowadays we do not require to do whether it is a posterior calyx and anterior calyx, because at the end of the day you have to find the shortest path. And in supine PCNL, most of the case we go through the anterior calyx only. So I agree with the Sanjay Natarajan that it is the generally target the laterally dilated calyx. Another question is that there is a question for you that in case of complex, in case of Staghorn calculus in multicystic renal disease, what is the approach in multicystic disease? Soumya, are you there, or someone can answer? In case of multicystic disease, that in Staghorn calculus,
Yeah,
Krishnendu,
let me come in.
this?
Yeah, let me come in. In multicystic kidney disease, the PCNL is not a very big issue. But the problem is that if we do first puncture and if we aspirate water, we think that we are in the PCS. We may not be in the PCS and just aspirate the cyst fluid. So in these cases, we need to put 2 to 3 excess guide wires and see it passing through the pelviureteric junction or coil in the upper calyx or lower calyx, and then put the retrograde contrast. We should not put the retrograde contrast so easily because it may just go into the cyst and then make the picture completely erratic.
So another point is in cystic kidneys, especially in ADP kidneys, I usually retrogradely inject diluted methylene blue or dilute betadine, because if you get a clear fluid, that it may be in the cyst. So if you inject a diluted methylene blue, if you get a methylene blue efflux, that means you are in the PCS.
Yes, yeah.
There is another question: is this what size of nephrostomy tube in PCNL is helpful? Like it is whether it is too smaller than Anomalous sheath. So nowadays, most of us do not put the nephrostomy tube. So what is the take of the panel? Gotam, you are putting nephrostomy tube in every cases?
No, sir. What I do is basically
size. The question is about size, I think. Not
the size, whether we are at all putting nephrostomy tube. Nabankur, you are putting nephrostomy tube.
No. Last couple of years I've left doing nephrostomy tube. For me, there are only 2 or 3 indications for nephrostomy tube, which is usually told by Pulsar. That is, if there is residual stones, I'm going to look for a second look PCNL. If there is a gross injury to the pelvic system, and if there is frank pus. Other than this, I don't think there is indication for nephrostomy tube. Nephrostomy tube does not prevent post-operative bleeding anyway.
Yes.
Dr. Sunirmal,
the question is whether tranexamic acid is contraindicated in post-operative hematuria due to clot retention.
We can ask some comments from Dr. S.K. Palsari if his sir is there.
Okay, sir.
Sir is there? I just saw his comment. Oh, yeah, you can go ahead.
So, panel, is tranexaminase contraindicated post-operative hematuria, post-PCNL clot retention?
So actually it is not contraindicated, but however tranexamic acid giving in the event of bleeding is a just cosmetic painting.
Yes.
If we don't do our work inside the kidney PCS in a good way and don't do a proper and precise puncture, then no type of anticoagulant will work, or coagulant will work.
Correct.
In case of the large stones, we are taking much time and there is a friction of the mucosa of the tranexamic acid can help to get the clear vision on.
But if there
So
is
I think
clot
all of
retention,
us
I
say
think
that
if you
only
give
you
tranexamic
use
acid,
it.
there will be more clots. So better to not to give tranexamic acid in case of clot retention. The question is basing on the clot retention.
Yes.
No, that case better not.
And one of the questions, Dr. Bera, directed to you, that supracostal puncture in inspiration or expiration. Again, the same question.
Supracostal puncture, usually what I do, the supracostal approach, I prefer general anesthesia.
No, sir, whether it is inspiration or expiration.
Safe is the expiration. Safe, always safe is in expiration.
Whether it is really needed in a expiration, because in general anesthesia, you are doing it in inspiration.
In general anesthesia, end tidal volume. There, you can stop the respiration and end tidal volume, and by deflating, not inflating the, at least not inflating the lungs. There is your safety window will be less if you puncture in the inflated lungs.
I have a question to Krishnendu. In the modern day, though in SSK hospital you have got a ESWL machine, do you think it is necessary to go for SWL in pediatric patients? Because you have got lasers, you have got mini PCNL, you have got also RIRs.
ESWL, what the literature? Hello, am I audible?
Yeah, yes.
What the guideline says, the ESWL and RIRS is the first option in a smaller volume stone. But what we see in practically, ESWL also requires anesthesia. Our ESWL suit is not fitted with the anesthesia machine, pediatric anesthesia setup. So we have shifted to stented RIRS in smaller caliber stone, and for larger caliber stones, we are doing the PCNL, pediatric PCNL. That's our.
So you think there is a need for change of guidelines? RIRS is more prepared
No,
now.
the thing is that pediatric ureters are more pliable, so they can pass bigger size stones. So if the ESWL suit is fitted with anesthesia equipments, Boyle's apparatus, we have done 1 or 2 cases experimentally that works very well. But as our institution is not having any extra Boyle's apparatus, and anesthetists are very reluctant to do that in this ESWL suit, that is the only hindrance. It is not the guidelines. It is our manpower and some
Yeah.
sort of.
Okay.
Yeah,
Dr. Surya, we have taken all the questions.
Yeah.
Thank
you.
Yeah.
Thank you very much. I think, madam.
I would like to
remarks.
end the session by thanking Dr. Choudhury, Sunirmal Choudhury. You have such nice nice names in this entire webinar. All sound so sweet. And thank you, Dr. Choudhury, very much, because you conducted this webinar in time and very precisely and chose nice topics for the same. And I would like to thank Dr. Malya, Dr. Soumya, Dr. Puskar, Dr. Saptarshi, and Dr. Joy Chakraborty, Dr. Nabankur Ghosh, and Krishnendu. Of course, Dr. Gotam too. So thanks, Surya, for suggesting Dr. Sunirmal Choudhury for this webinar. And I think we started this year with PCNL, and now we are ending the year with PCNL. And it's a favorite topic, and there were lots of attendance tonight for the same. I thank all of you for attending all our webinars, and see you next year. Thank you and good night.
Thank you.
Thank you, madam.
Good night. Good night.
Thank you,
Thank you very much.
Thank you very much. Thanks to all the speakers. Thanks, Sunirmal. Thank you very much.
Thank you, sir.
Thank you.
Thank you, Surya.
Thank you.
Thank you.
Thank
Surya,
you.
thank you,
Thank you.
thank you. Thank you for the good session.
Sorry,
Yeah.
can I pass one comment? So
Please.
unfortunately, I was not here for the whole time. So I heard bits and pieces. What I can say, first, there's some message for the residents. What Madam Sujata was telling is very right. So most of us, after passing out, will have to do PCNL. You have to learn PCNL, and you should learn only, I mean, one, and then you can change. And the best part of PCNL for the last 20 years, I don't think there is any change in the guidelines. So if you find a case of stone disease nowadays, I think it's easier to answer, and that way it is for the exam going. This is the thing, and I think I am hearing the same sort of discussions, but the way of presentation is definitely different, and it was a very nice presentation. So I congratulate all of you for this, and I congratulate the ISU for starting with PCNL,
Thank
the
you.
repeating, and PCNL.
Thanks.
Okay, thanks a lot. Good night.
Thank you,
Thank
Uttam.
you. Good night.
Thank you,
Good
Uttam,
Thank you,
for
night.
sir.
a
Thank you.
wonderful conclusion. Thank you, Uttam. Thank you.
Thank you.
Thank you, sir.
Good night.
Yeah. Good night.
Good
Good
night.
night. Good night, ma'am. Thank you, ma'am.
Thank you.
Thank
Good
you.
night. Thank you. See
Thank you.
you.
Thank you. Thank you.
Bye.
Bye.